going to capitalize on this silence to start now. We have like 2 minutes to spare, so. I'd like to thank you all for coming. Welcome to Treaty 6 territory in the traditional homeland of the Métis Nation. We are very happy to host you. We will start with an opening prayer from Judy, and I would like to invite her up to the stage, please.
Good afternoon. I'm not going to say the prayer right away. I just want to give a little bit of background on myself and some of the work that I do. I'm a private contractor. However, my primary biggest contractor is with the Saskatchewan Health Authority. I work with mental health and addictions in Saskatoon. Excuse me. I've been working for the Health Authority now for almost 4 years, and prior to that I was a Dean of Health for the Saskatchewan Indian Institute of Technologies. And at that time, just kind of sitting up in my office and looking at curriculum on mental health and addictions and all the things that are in it, and never really realizing what's out there. And when I retired in 2015 and took this job, I went into the gutter and I saw what's happening out there. And I want to say that it really opened my eyes. You read it in books, you see it in internet and whatever else. Every single day I see it now. One of the first things I did was to volunteer. I wake up really early, so I instead of just laying around, my first stop is usually at the brief detox, where people go to detox from alcohol and drugs. I go there every single morning. I was there this morning, and many people come, and for many reasons. A lot of them lately have been women that have been hooked on crystal meth and looking for help to get back, usually to get their kids back that have been apprehended. I also go to the homeless shelter at downtown Saskatoon, always full to the brim with people laying around all over. Some of them tweaking, some of them sleeping on cement, some of them whatever, and a lot of them outside, some of them are drunk, some of them are going there just because they have nowhere else to go. So when it really opened my eyes to what's really there. We live in our cities, we sleep in our comfortable houses, but we don't think about what's out there, what's really out there. And sometimes to take a look at what's the disparities that are there. And unfortunately, the Indigenous people are overrepresented everywhere, in the hospitals and acute care system, and everywhere we go there's HIV, there's diabetes, and crystal meth addictions, opioids, everything. There's a high proportion of Indigenous peoples. And I think that just before I got here, I was at the city police station, and I was listening to my colleague Gilbert Q-Step, who was an elder. He's a professor with the First Nations University of Canada, and he goes and he tells his story about what it was like to be through their Indian residential school system, and it really gives you a sense of why this is happening. And many people don't ever see that. And I know that I worked with researchers, and I went to a conference in Toronto and talked about as a patient family advisory group, and talking about some of the things that are happening in inner city. And many times you look at statistics and research and numbers and stuff, and you don't really see the people. And I'm very proud of our Waniska group here. That's the theme of our conference. Very proud of them, that the things they're doing here. I also am a cultural advisor for them as well. I actually work for researchers with the U of S. I work with FNUC, with the Saskatchewan Health Authority. I belong to actually about 40 committees and little groups where Gilbert and I and other elders are working together. But with Gilbert's story this morning, every single time he tells his story, I've been there to support him. And he cries, and he talks about how life was before residential school, when you're living in a bush and everything was cared for. There was love, there was healing through natural, the land and all the love, and everybody had a role. Everybody had a role right from childhood right till elders. Everybody had a role to play, and it was good. It was a good life. And he talks about how in 1963 they went to buy groceries in Hudson Bay, and his life changed forever. And how the black people in black robes came and took all the kids in the car and just took them off to residential school. And his grandmother was there, and he said, I look back and she's crying and crying. He said, once I got into that school, my life changed forever. The things that happened in that school are horrific. And I know my mother was in residential school, as was I. And nobody here is to blame for what happened in that time in history. But what we have the responsibility for is to learn about it. Because none of those drug addicts, none of those people, those kids that were apprehended ever choose to say that, you know what, today I'm going to abuse alcohol, and I'm going to give up my kids to the system and stuff like that. They are intergenerational survivors, or not, they're not survivors, I should say. Intergenerational trauma has taken over a lot of our people. And once you learn that truth, we could start to work together. Because it's all relative. All the overrepresentation in healthcare and criminal justice and in child apprehension is more than it ever was in residential schools. All the people that I probably about 10 to 12 circles I do with women at risk and women that are apprehended, that are living in halfway houses. Those are the intergenerational trauma. So once we start to, I think that I would challenge you with TRC and calls to action to do a little bit of research, and then you'll understand why. So when you learn that truth, you can start to learn, all of it is relative to that. I'm a result of that. I'm a residential school survivor. I've suffered sexual abuse as a 7-year-old. I've been an alcoholic. I'm a recovering alcoholic. For 22 years, I've been clean and sober. I've attended university and got a couple degrees, and I've done things, and now I feel the Creator put me here in front of you today for a reason. And Creator put me even through all the things that I went through, all the horrific things I went through as an alcoholic as well, and to bring you, to bring people some of my lived experience, and like Gilbert and I really work together in bringing that understanding to those of you who can. So I challenge you to do the best you can to learn as much as you can about intergenerational trauma, and it will help you understand the overrepresentation of our people. So with that, I'm going to say a prayer, and I'm going to say it in my language. We don't usually use a mic, but I would also like to tell you that I will pray for you, that you open your hearts and your minds, and have a really good session. This is excellent. I'm just really, really proud of all of you for wanting to understand and being here. And I wish you a very good conference. I'll be in and out, and probably you'll see me around right till Saturday. And I'm welcome to Saskatoon. So I'm just going to say, bow your heads, and you could say it in your own way, whether it's to God or Jesus or the Creator and your higher power as you know Him. Amen. Thank you.
Thank you, Judy. So as I mentioned, my name is Sigenli Del Canto. I'm with Share and Reach. And as I mentioned, did I mention in this room? I can't remember. My ancestors are from Sri Lanka. I was born in Toronto and I've been living here for 10 years, 9 years. I'd like to begin by acknowledging our sponsors. So thank you to the Canadian Society for International Health, aka the CSIH, as well as CAR, the Canadian Association of HIV Research, as well as the Saskatchewan HIV Collaborative. I'd also like to acknowledge our partners in putting this together. So REACH, as I mentioned before, the Community-Based Research Center, Biolytical, Two-Spirited People of Manitoba, Manitoba Minopiwatsuin, Model of STBBI Care, CATIE, the Sex Now Survey, and the National Collaborating Center for Infectious Disease. So as you may have read in the poster or in the program, so last year we held an ancillary session for CAR 2018, also focused on HIV-STTBI testing. And today's session is meant to build on that, so to carry over the conversations that happened then. If you were there with us last year, welcome back. That's a good sign. And if this is your first time here, hello. And this session today is also kind of setting the groundwork, preparing everyone for the special session happening on Saturday evening, which I know you're all going to be there, because I can see you. Okay. And then just to give a bit of context, so our objectives for today are to identify and evaluate research studies on alternatives to standard HIV testing approaches, to compare and contrast HIV testing alternatives to the standard approach, and engage meaningfully in policy-focused discussions on HIV-STTBI testing in Canada. And then at the special session, you'll learn to describe the advances, challenges, and opportunities in implementing and scaling up HIV and STTBI testing options in Canada and context for ensuring successful linkages to and retention in care. Whew, that was quite a sentence. Okay. As well as discuss how implementation science can offer an approach and the pragmatic solutions to testing and linkage to care for the undiagnosed that can lead to the end of HIV epidemic in Canada in 5 years. So, I treat gatherings as ceremony. Anytime we have a group of people in a room, a meeting, a conference, a workshop, what have you, it's ceremony. And as such, I urge you all to call your ancestors into the room. And so as introductions, what I propose is we each say our name. You're welcome to say where you're from if you want. And I ask you in 10 words or less for your entire intro to tell us where your ancestors are from. So 10 words or less, your name, where your ancestors are from. And we will start this way and we'll kind of sneak through and then go through the back here. And one last thing I should mention is that this session is being recorded. It's not live streamed, it's being recorded, and it will go up on the Saskatchewan HIV Collaborative website. Most of you will not be in the recording. We're not entirely sure, but possibly the first 2 rows will be, and I have media release forms I'll pass out to you. But if anything, it'll be the back of your head that's recorded. Okay? So may I look to you to start?
So no, I'm not Sweden. And so I'm also a French guy, so nice to meet you.
Isabel, I work at the McGill University Health Center. I am French Acadian and my ancestors are from Europe.
I'm Luciana Fell. I work at Portail HIV
HIV-AIDS for politics.
AIDS Portal of Quebec. I'm trying to say it in English. In Montreal, and my ancestry is from Catalonia, France, and Germany.
My name is Judy Kelly. I'm an Anishinaabe from Hawaii First Nation.
John came from the National HIV Labs in Winnipeg, and my ancestors are from the highlands of Korea.
I'm Suzanne. I live and work in Treaty 4 territory. I'm a settler. My ancestors are from England, Germany, and Austria.
And I'm Rick Galley. I'm with Bioanalytical Laboratories, and my ancestry is 100% Italian.
Hi, my name is Albert McLeod. I'm with the Two-Spirited People of Manitoba, and my ancestry is Cree and Scottish.
Hi everyone, my name is Nathan Lachowski. I hail from the Fleming-speaking territories on Vancouver Island. I'm a settler with ancestry on Ukrainian and England.
Lori Eggleston, I work at Katie. Our office is in Toronto, but we work across the country. And my ancestors are from a smattering of European countries. I'm a settler from, I don't know how long ago, for a while.
Excellent. Thank you, everyone, for sharing that. I appreciate it. Did I share? Oh, I think I did. But just to be safe, to close the loop, I'm Sagandi Del Canto. My ancestors are from Sri Lanka, and I currently live in Treaty 6 territory, homeland of the Métis Nation. The last thing I will mention before I turn it over to our wonderful moderator, Lori, is that we have two note takers in the room who will be kind of just taking notes of the conversations that happen. And I just want to assure everyone that no names will be used in the report. And if you want to receive a copy of the report when it's ready, I have a very high-tech sign-up sheet. And so all I ask is that you add your email address to it. And then when the report is ready, I will use this list to send it out to everyone. And with that, I'd like to turn it over to Lori.
Thank you, Sagandi. Isn't she great? She was trained at Katie. I take some credit for that. So, as I said earlier, my name is Lori Edmiston, and I have the honor of moderating this session. I work at Katie, and I also, Suzanne is on our board, and Darren, if you raise your hand at the back, is also on our board, so feel free to ask any of the three of us any questions that you have about Katie at the end of the session. So we've got four speakers, and I think how we're going to do this is the speakers can either speak from where they are sitting, or they can come up to the mic. They have approximately 15 minutes for their own, well, a maximum of 15 minutes for their presentation. And then before the next speaker, I'll ask if there's any questions of clarification. Any sort of more discussion questions, I would ask you to write down so you don't forget, and we will have hopefully some time for a robust discussion of all the issues that the four presenters have raised at the end of the session. So I'd like to start introducing Nathan Lachowski. Nathan works for the Sex Now survey and CBRC, which is run by CBRC, the Community-Based Research Center, located in Vancouver, but doing work nationally now. And he's going to be speaking about results from the Sex Now survey, and in particular talking about dried blood spot self-testing. Got that right?
Yeah.
Great. Okay, Nathan. Yes.
And then pull me off.
Okay.
Hi, good afternoon, everyone. I figure I'll stand up so you can all see me well. Nice to see you all. Thank you for coming. I know there's lots of competing sessions, so it's nice to be picked. As Lori said, I'm going to be talking about this survey that actually has a much longer history than I do with it. And I'm mostly going to try and talk about our process, because I think that's actually kind of where the innovation is in terms of thinking about testing. So some of the other folks will talk more about the technologies of the actual testing, but I'm going to try and talk a little bit about our process. So I'm going to start with a bit of a history of this survey, where it kind of is based within and what it's done over time. And then I'm going to specifically kind of talk about 2 different components. And I'm going to do this all within 14 minutes and 45 seconds. So this really started based on a concept of action research by and for gay men. So there's some photos here of some newspaper clippings from the 90s that really you can see kind of depicts continuing stigma that places blame on individuals from affected communities for ongoing HIV epidemics. And so this organization was founded in Vancouver in 1999 around a kitchen table. I think that's where a lot of really good work happens and continues to happen in our sectors. And so I think it's nice to have been able to have food and share food. And they really were interested in this concept that of this adage that people will know well and nothing about us without us. And so really we're fundamentally about this aspect of working from within community to create capacity and to run and have authority over our own processes. So when the organization started, it got connected in terms of other folks around the world that were doing work around community-based research. And so they had a gathering in the late 1990s and created this document called Communities Creating Knowledge. And this was kind of a consensus statement on community-based research. When I think about this in terms of my time, I was just a young wee lad in the late 90s. And I think when I think about where community-based research has gone over that period of time, some of it is exciting and some of it is incredibly frustrating that 20 years ago we had a consensus statement that talked about the same kinds of things that we continue to push against within research and academic structures. So, but that's a talk for another day in some ways. And so they were very interested in leading surveys on their own communities. And so they started with a street survey, very shoe leather epidemiology for those of epidemiologists in the room, of going onto the street and just asking folks, what's going on with you? What are your health priorities? What are your health concerns? And that continued to kind of grow over time. So as Laurie said, the organization's based in Vancouver. And over the early 2000s, a number of surveys were done across BC. And then the internet came. Folks may remember the era before internet. I certainly do, growing up on a farm with dial-up internet, and that was like a major step. And prior to that, I think we did a lot of stuff in person. And when we went online, a lot of that was to try and reach folks that we weren't reaching in person. So a lot of good value in terms of doing that. We know that not everyone will show up or is able to show up to certain kinds of spaces. But at the same time, we also lost that in-person connection. And so this past summer in 2018, we were able to go back in person to run this survey. And so I'll talk a little bit about that in more detail. But here's what the survey looked like in the beginning of the 2000s when they started it. It was a paper survey doing super low technology, a bunch of folks from community wearing some branded t-shirts so people knew who we were, and then going and spending time, and a lot of the collection happened at Pride festivals. And literally asking folks to take time out of their day celebrating to fill out a survey and do some research. I think that's one of the things that I find most amazing about working in community is that folks are willing to take time. If you create space and opportunity, they absolutely, do you know what I mean, will meet you there. And so I think that's why it's important that we do that. So in terms of 2018, these were the partners that we worked with across the country. A number of different community-based, public health, some different academic organizations. Our lab testing was done with John Kim's group at the National Laboratory for HIV Reference Services. And what we basically did was travel across the country with a paper survey and went to Pride festivals. Was this at all hugely innovative? No. This was not the first time it had been done. In fact, it had been quite a while since it had been done, and that's part of what we were interested in. And we knew that that's a space where a lot of community gather, and so we kind of think about this in terms of high volume. When we start thinking about testing, is that we know that there are a lot of folks that we can engage with really quickly and really briefly and get people through this study. The study covers a broad range of health issues, and I'm not going to talk too much about that, so I'm going to try and focus on the kind of testing process. So we basically had doing people in community, collecting paper surveys, and then completing a dry blood spot piece. So how many people, by show of hands here, have heard about dry blood spot technologies before? Okay, maybe let's flip that around. How many people have not heard about dry blood spot technologies before? Okay, then great. So I don't really need to talk about this, which is good because I didn't actually put many slides in about it. What's different, I think, maybe than what people might know, I guess, is that we were really interested in doing this kind of peer-based, community-based collection. So we did these training sessions across all of these different communities and did a kind of train-the-trainer kind of model. So we taught folks in community how to collect a DBS, how to do our consent process for the survey, And then participants we had this kind of passport that people would follow through. So we had a consent process, and then folks would fill out the survey, and then they would choose if they wanted to also complete a dry blood spot or not, okay? So again, I think this element of choice was very important in our design, that we let people opt into all of these options. If they then did their DBS, they could self-collect it if they want, or we could do the peer collection. Most people opted for someone else to prick them. It worked really well in a kind of pride context and a kind of sexual health space to talk about, it's just a little prick. It won't take long for us to finish. So that was kind of like, we were trying to have fun with it and make it relevant for community. And we were really amazed at the uptake that we had with that. The other piece that was the next kind of level of consent was that if folks wanted to, they could participate completely anonymously. No name, no contact information. So they would just be contributing data for the value of research and the community benefit. But if they wanted, they could actually provide us with an email or a phone number and ask to get the results of their DBS cards. And that was something that was important to folks in community, saying, if you're collecting my blood and part of my body, my spirit, and you have information on me, then we have a right to that information. And so that we provided that option to folks, that if they wanted that, they could get that back. So then we went around to Pride festivals, and we went to a variety of events at Pride festivals, and I can talk more about that, but 15 cities across the country. We had hundreds of volunteers that came out and spent time over the weekends doing this collection. So many thanks to all of those folks. And we collected in the end over 3,000 dry blood spot cards. And those cards were able to be screened for HIV and hepatitis C. What you can see here are kind of the cards that were in the racks. We used an anonymous number code between their paper survey and their dry blood spot cards to be able to link them. And then these were all packaged in great detail with all the necessary materials and then shipped to John's lab in Winnipeg, where all the testing was done. And then those results were sent back to our team and then linked back to the survey results. I want to talk a little bit about the returning results process because I think that is quite important for us. We thought a lot about this in terms of the implications for what this would mean for someone. Of course, in a large survey like this, we're not expecting to have a ton of folks who are unaware of their status, but nonetheless, that certainly happened. And so this was really about thinking about in detail about what our linkage to care process works or looks like. And because we had worked with all of those partners across the country, we were able to already have a relationship, and many of those partners operated health clinics or testing services or had very close relationships with folks who did. And so when we went back to people, so this is a photo of Len Tooley, I should explain who this person is. And Len was the person who was doing that results returning, so a peer-based results returning system. And we had pre-arranged in all of the different sites that we had folks that had results to get back, a linkage to multiple options. So thinking about, here are some direct places that you can go to. We've pre-talked to those places, not about you, but in the background we had done that work to make sure that those folks would know that you might have someone who's going to contact you and they might tell you they're from this study and this is the background on that, and if you can help expedite them through testing, we were really making sure that people had access to confirmatory testing in a clinical setting. And that was really new territory for surveillance studies, which you can kind of think about the Sex Now survey as. But it also obviously came with many challenges. And so I'm happy to talk about that more in kind of discussion period. But overall, I think during this worked well, and we were able to get results back to people. In many cases, these kinds of studies have occurred before, and never have people been informed about their results. And so this was a very big shift for us, and it was a big part of our ethics protocol review to make sure that we did so in a safe way for ourselves as researchers, for the participants that were going through it, for the institutions that are concerned about liability. So I'm happy to talk about that as well. And I think the other thing that I'll just mention in terms of doing large community events in terms of this is you are very exposed to the elements and the weather. And there was a lot of rain that occurred at Pride festivals across the country. Some parts of Pride that we were planning to go to got canceled. Others had lower turnouts than we expected. And that's something that I think if you're doing community-based testing at large events, you can't really change, but it is something to just be mindful of. And I guess the one other thing I'll talk briefly about, thank you, is that we did have some partners who offered parallel kinds of experiences. So lots of those folks would be doing education or outreach, providing harm reduction supplies, condoms and lube, things like that. Our own health center, which is a community health center space in Winnipeg, was also offering point of care testing. So they were doing rapid point of care testing parallel to the study. So folks could either do the study and point of care, they could do just the point of care, they could just do our study, or they could do neither. And so it was interesting in that kind of setting to see who was choosing what different kinds of options. It wasn't a part of our research protocol, so we couldn't really do systematic evaluation of that. But I think what was interesting is some of the conversations that we had with people when you're sitting there. And when you're doing dry blood spot collection, for anyone who's done it, I mean, you've got like some intimate minutes there, you're holding someone's hand and talking to them. You learn a lot about a person and get to really make a relationship. And some of those people were very interested in not getting their results right away. When they were at Pride, they were there with their friends, you know what I mean? And they didn't want to like get a result immediately. Other folks were concerned that, I'm going to give you this dry blood spot, and then you're going to have to send it to a lab. It's going to have to get tested. It's going to have to get sent back to you, and then you're going to tell me. And they're like, I want to know right away. And so I think this really speaks to the fact that there will never be a one-size-fits-all for this, and that choice is a very important piece, and that people have an informed process to be able to understand what engaging in those various choices will mean, and that we've thought through, if we're offering those choices, making sure that there's a safe process for people to go through. And so the last part, I guess, is Sex Now 2019 online. So as you would have heard before, we did a lot of surveys online. And part of what we asked about in 2018 was, would folks be interested in receiving an at-home collection kit? In 2014, we also asked these questions about at-home HIV testing. And so in that survey, 71% said that they would use an at-home HIV test. And a third of people actually said that was their preferred choice for their next HIV test. If they had all of the choices available, they'd prefer to do a home test. And so what we've decided to do with Sex Now 2019 is a very similar process to in-person, but given that we're recruiting and people are completing surveys online, is that they can opt in online to receive an at-home DBS kit. It's the same materials that we get from PHAC in terms of doing the testing. We will then send those kits to people, and we've put together a bunch of materials to let them follow through in terms of being able to do that self-collection. We have a fun video of folks from going through it themselves so they can follow along with the video. They've got printed instructions. And what we're looking at here is who's interested in this, who's going to take it up, and are we reaching different people? So we have our last REB meeting in 2 weeks with the UVic REB around this protocol. And then we will launch this summer in terms of the survey. And we have the same process as we did for in-person in terms of if people want to opt into results, they can, and we will go through that same process again. So we're really excited about this because we know that Pride is a space that is not safe or accessible to everyone. We also know that they're largely urban-based events that we went to, and there's a lot of folks across the country that wouldn't be able to access those spaces. So the idea of having this blended in-person and online community-based process, I think, has been quite exciting for us. So I don't have any results about that. In terms of the community uptake from the in-person, I should have put this slide before, we were able to reach key subgroups that I think often we sometimes think about our HIV priority populations in very siloed ways. And for people who live at those intersections, they know that during being a black gay man is you can't separate those things out. And so in terms of some numbers from our in-person, we had 6% of folks who identified as Indigenous, 8% who identified as transgender, 28% who were born outside of Canada. And then in terms of the testing numbers, half of folks had basically not been tested for Hep C in the past year. 2/3 of folks had not been tested for HIV in the past year. So in many ways, this kind of speaks to the piece that if we build it, they will not necessarily come, that we actually have to go to them. And I think bringing this to a community space provided an opportunity for folks who otherwise might not have gone out of their way to seek testing. And so I think that's quite important. We had, over 85% provide a sufficient sample to be able to use for HIV testing. And of those samples that were collected, highly valid. So that was really great, I think, in terms of thinking about running this in a Pride setting through high volume where you've got hundreds of people a day and community-based collectors. I think that was a really great outcome for us. And 70% of folks said that they provided some form of contact information to be informed about the results, which was actually much higher than or at least that I originally expected. So that's kind of a little bit around how things went with our in-person survey. So thanks to all the gay, bi, queer, trans, and two-spirit men who participated. Thank you to all of our community partners and the National Alliance who supported this study. To all our staff and volunteers, this is a photo of Rob Higgins, who's been managing the survey over the past year and a half. The hundreds of volunteers that I talked about, our research working group members, and our funders. So this survey was supported by Canadian Blood Services, and then also in kind from Public Health Agency of Canada. Thank you.
So you can tell that Nathan is a very experienced presenter because he was bang on 15 minutes. Any questions of clarification for Nathan? And if you do, could you use the mic? So for those of you who came in after we started, we're going to entertain questions of clarification after each speaker, but any more questions, larger questions, discussion questions, we're going to save until all four presenters.
Nate, just a super quick question. Was the dry blood spot testing just for HIV, or because I noticed you had hepatitis C kind of rates on there as well?
Yeah, so in the in-person survey, we did screening for HIV and hepatitis C. And for the online, we are adding syphilis. So we'll have those three in the online portion that's to come. Yeah. I look forward to discussing with you all later then.
I have one other question of clarification. So for the people who didn't provide an email or a phone number to hear their test results, how are you going to be getting those test results back to them?
Yeah, so, I mean, for us, that was an aspect of their consent and their autonomy to decide, and so they chose to participate anonymously, which was the standard that basically happened before. So for those people who didn't want it, and some people didn't do that because they were like, I already know I'm HIV positive, and so you don't need to tell me that again. So we know from the conversations with folks that was some people. For other people, they didn't want to know, and they were happy to support the study and that process, but they didn't want that result. And so for us, that was an aspect of consent that we gave people the option, and so if they opted not to, then they wouldn't.
Thank you. So our next speaker is Albert McLeod. Albert comes from Winnipeg, and he works with Mino Pimatsuen. Did I say that right? Good. The Mino Pimatsuen STTBI project. And Albert is going to talk more about dry blood spot testing on the ground.
Great. So this presentation, I'm just giving you an overview of introducing HIV testing and innovative testing outside an urban center. And this is at the 31st Annual International Two-Spirit Gathering that happened in August 2018. So the title is Introducing Rapid HIV-STTBI Testing to Indigenous Gatherings. This is me growing up in Manitoba, and I came out quite young as a, about 11-year-old as a queer person in a Cree family, and I ended up living in Vancouver 1979, which is really when HIV was being introduced into Canada in our large urban centers, and met a lot of other Indigenous queer men primarily in these urban centers, and in the following years we were greatly impacted by HIV and AIDS, and experienced that first wave of HIV and AIDS cases in Canada. This is me with my friend in Vancouver on Granville Street, about 1993, when I began to work in HIV. So one of the responses to HIV from an Indigenous lens, again, because gay males were primarily the first ones who were Indigenous who became infected with HIV. First Indigenous AIDS cases were among gay males, men who have sex with men who were living in large urban centers. In 1988, we collaborated not just around HIV, responding to HIV from an Indigenous point of view, but also looking at our identities as queer Indigenous people, looking at culture and ceremony. And then we also received opportunity and support from government health agencies around 1986, in that we were, at that time, we were kind of the first Indigenous people who began to attend meetings around HIV with government, began to do some HIV research, and that time it was very stigmatized. It was difficult to get people to the table. It was difficult to get people to talk about AIDS. And so a lot of Two-Spirit people were those first groups of people who became engaged with systems and governments in terms of the Canadian response to HIV and AIDS. And then further from that, some Two-Spirit people became leaders in the Canadian-US responses to HIV and AIDS. Now, our gathering that we had in Manitoba in 2018 was the 31st. And I like to profile this as an Indigenous response to HIV, whereas for some people just sort of coming into research or learning about how systems respond to HIV and STBBIs, we've been doing this a long time as Indigenous people. And so our gathering is part of our response. It's culture-based. It's about making a safe space. It's about learning about identity and culture and resilience, but also acknowledging that we are survivors from the first wave of the epidemic in Canada. And this is, I call this a community response to the AIDS crisis. And so these are the different sites, the 31 places that we traveled across North America. And I said there is a collaboration with our colleagues and our peers in the United States who went through similar experiences. And so it's kind of like the Amazing Race gay Indigenous version. And it's like, you know, plane, train, boat, bicycle, hitchhiking, however you can get there, that's how we've done it. And, you know, when you talk to systems and government and we talk about, you know, determinants of health and cultural safety, this is, we were doing decolonization way back then. We were doing reconciliation way back then ourselves in terms of reestablishing our identity in the landscape of North America, reclaiming these spaces physically by traveling to them, meeting the Indigenous people, learning about the Indigenous landscapes of these territories, right? So we began this a long, long time ago. What we do there is we have traditional foods, we camp, we have sports, we have sweat lodge ceremonies, healing ceremonies. We have a two-spirit powwow. We have sharing and healing circles. We have weddings. We do social networking. We do health and skills workshops. We do two-spirit entertainment, which is a metaphor for a drag show, and lesbians reading poetry or singing folk songs. We have access to elders. We do traditional crafts, cultural teachings, rites of passage, and then we explore cultural sites. So the issue, though, is that it's only 4 days out of the year that we make our culturally safe space. And ideally, it would be every day. So when we think about the work that we're doing in research or health and Indigenous people, this should be every day in Canada and the US for Indigenous people, that we live this life, right? That's what Minnow Pamatsuin means. It means the good life, right? So that's what we're striving towards. So if you look at HIV stats in Canada, and this is an overview from 2016, majority GB MSM. And again, that's a long-term issue in Canada, why gay or bisexual men are still becoming infected with HIV. And that hasn't changed for decades. So that's still something that we need to address. And that two-spirit men or two-spirit people are counted in these numbers as well. And then estimated number of people with HIV, the point estimates the one in between. So you can see after, like, even after 2008, still increasing in Canada. And then we look at the Indigenous data, estimated about 6,000 Indigenous people in Canada at around 2016 living with HIV. And usually, I'm not sure how many are actually reached through any formal way in Canada, through an AIDS service organization, or that we don't know how the 6,000 people are even connected to services in Canada. Now, when we look at HIV testing, the US, in terms of Indigenous people, have been ahead of Canada in a lot of ways. And part of why we asked for HIV testing at our gathering last summer was that in 2003, I was at a Two-Spirit gathering in Montana, in the mountains, in a cabin, and they were providing rapid HIV testing to the delegates. That was in 2003, right? And still today, we don't do that same type of testing in Canada, right? That was like, how many years ago? 15 years ago. And so a lot of ways, Canada is very conservative in its attitudes towards providing, testing to Canadians. Now, this was at a powwow, the 8th annual Two-Spirit powwow in San Francisco. And right at the beginning of the program, they start with gourd dancing, and they announce HIV testing opens, right? This is the point of care test, the rapid HIV test. And this is how normalized it is in the Native American community in the US, is that at a public powwow, there are services there are people there to provide rapid HIV testing, right? Something that in Canada, I don't think we can even conceive of doing today. Like the powwow circuit in the US and Canada is huge, thousands and thousands of people. Sometimes up to 4 days, thousands of people will go through that powwow area, and that in the US, it's normalized to them that they could have a rapid HIV test, right? So still a lot of work to do in Canada. Again, in California, a youth identity summit. This was from last year. So NAHC's Circle of Healing will be offering free rapid HIV testing during the Youth Sexual Health and Identity Summit. One of the most important things you can do in HIV prevention is to learn your status. So here's rapid HIV testing focusing on Native American youth at a public event in California. We don't do this in Canada at all, right? So in terms of Manitoba, these are our HIV testing options. And this is a poster just sort of promoting testing. Where to get an HIV-STI test, a requisition for a blood draw can be provided by a prescribing clinician. Multiple drop-in HIV testing locations throughout Winnipeg. Point of care or rapid testing is currently offered at 9 Circles, Main Street Project, Our Own Health Center, and Street Connections. And then dried blood spot testing is offered at various advanced testing initiatives. And then 9 Circles Supply Distribution Room is coming soon. Where's that, John, with the 9 Circles? In progress. Again, a statistical update on HIV and AIDS. For Manitoba, 109 cases in 2016. A continued upward trend in new HIV cases in Manitoba. Yeah. And then, I'll just skip through these. So these are some of the Indigenous stakeholders who can be approached around testing at events or any kind of activities or any introduction of innovative testing. This is the Collective Impact Network that we work with, and this is really the network that facilitated the testing that happened at our event. It was the intersection of different disciplines of people that came together that created the opportunity and the conversation to deliver the testing. And so it was Our Own Health Center, Gay Men's Health Center. Their team, we recruited them and they volunteered. It was a long weekend. And so this is the point of care testing kit. This is how you analyze the results. And then Dr. John Kim, and they brought their dried blood spot test for that day. And then they also had done the Sex Now project at last year's Two-Spirit powwow that we had in Winnipeg during Pride. And so this was the wellness tent that we set up at our gathering on the Saturday afternoon. And the team came out. There's some volunteers, the testing team. So 29 point-of-care tests were done for HIV, and then 20 dried blood spot tests were done for HIV and hepatitis C. Lessons learned: the annual International Two-Spirit Gathering is a culturally safe response to HIV pandemic. Some Indigenous communities are ready to offer rapid HIV testing. Two-Spirit Gathering participants accepted the testing as normal. Testing can be delivered in rural outdoor locations. The Manitoba HIV-STTBI collective impact model supportive, effective collaboration between diverse sectors and across jurisdictions. Our own health center was able to quickly deliver point of care and pay for the test kits from charitable funds. Manitoba requires a standardized process for events-based testing, and increased collaboration with American Indian, Alaska Native HIV/AIDS initiatives will benefit Manitoba. So what's our time? Done? On good point? I'm gone? Okay, thank you, everybody.
I didn't mean you were gone. I meant your time was up. Okay. Any questions of clarification for Albert? Okay, thank you. We have Rick Galley is next. Rick is from Biolytical, and he's going to be talking to us about self-test, the INSTI self-testing results or research.
Thank you. Good afternoon, everyone. It's a pleasure to be here. And what I'm going to do today is introduce you to the newest test in the HIV testing toolkit, and that's HIV self-testing. And not too long ago, many of us would never have thought that self-testing was going to find its way into standard use. And certainly that's becoming a reality. And what I'd like to do today is share some results of some studies that were conducted recently in sub-Saharan Africa, and some of the background around these studies, some of the lessons learned in these studies, introduce you to where self-testing is in the Canadian landscape, and then finish with a few open questions that hopefully will stimulate some conversation at the end of this session. So I'm going to start with the sharing with you some of the performance, usability, and acceptance of the blood-based INSTI HIV self-test in high and low HIV prevalent populations, and these were studies that were done in sub-Saharan Africa. So this is what the test looks like. There's two versions of the self-test. Both have the same contents. One's in a bag, one's in a box. The box version is likely going to go on the shelf in a pharmacy at some point. They don't like bags, they like boxes. So boxes fit on shelves, bags fit on clips, and they prefer to have boxes. So, HIV is entering into the retail world, which is a whole different game. These tests are very similar to the point-of-care test. They were patterned and designed after the INSTI point-of-care test, which has been in use in Canada for a long time. Although, as Albert explained, Canada has a lot of inadequacies in point-of-care test delivery, and you'd think they'd address those first before introducing self-testings, but it's it's a reality now. So these tests are very fast. They can provide a result in as little as 1 minute, and so it's a really good fit for a self-testing environment for people who are ready to self-test. I'm going to share very quickly some data from 4 studies that were conducted in 2017 and 2018. I'm going to list the studies first and then share the results after outlining the study designs. What happened? There we go. So the first one, called H*001, this is a study that was done with Wits University Reproductive Health Institute in Johannesburg, South Africa. This was purely a usability study. The purpose of this observed usability assessment was to document if lay people, these are non-professional, inexperienced in HIV self-testing, can successfully perform the steps to use the test without any product familiarization. So basically open the package, read the instructions, do the test on themselves, and then someone would observe to see if they could perform the test correctly. So the primary objectives, as you see here, were to document and record label comprehension, were the instructions easy to follow, usability, that is the user interaction with the device and the accuracy of the testing process, not the results, and results interpretation was done by contrived results. So they don't interpret their own test result, they interpret mock results and ask to see if they could identify a positive, a negative, or an invalid. So these subjects were observed performing the self-test procedure but did not interpret their own results. And this is a typical participant demographic scale. This particular study had 200 subjects. None of them had ever experienced self-testing before. Gender distribution was fairly equal between male and female. Age between 18 to 65, but the majority were 18 to 35. Stratified basically 1/3 with some primary school, 1/3 with some secondary, and 1/3 with some, at least some college. And almost half of the participants were unemployed. And this will show you some of the outcomes. This is a this is the outcomes of the usability aspects. There were very high performance on being able to complete critical steps correctly. The mock results were interpreted correctly. Device and the instructions for use easy to use. You can see that these attributes all scored quite high, but there was one exception. Only about 85% of the subjects in this study were able to successfully have a blood drop fall from their fingertip into vial number 1. So in other words, there were some failures here, and that number was not going to really be very useful. So things had to change. So I'm just going to go through some of these. Study number 2 was performance and usability evaluation of the INSTI test in Kenya. Now this was an actual field study, and the results were published in PLOS ONE recently. So if you're interested, the reference to that publication is here. So Kenya has an adult HIV prevalence rate of 5.5% roughly, with approximately 1.6 million people living with HIV. Of these, approximately 53% are unaware of their HIV status. And in 2017, a collaborative study with the Clinton Health Access Initiative and Biolytical, along with the Kenya Medical Research Institute, was performed on the usability and performance of the INSTI test. So this study design was a cross-sectional observed study of consenting adults in Western Kenya, and it was conducted at market centers, village squares, and supported, importantly, by village chiefs and country and county administrators. So this study had to have the approval of the village administrators in order to proceed. Methods comparison, usability, and readability were the 3 elements that we looked at. This is what a package insert looks like. It is very pictorial. There is not a lot of words, and this is what the self-testers would follow. There'd be English on one side, and in this case, there was Swahili on the other, and this is what was used to conduct the test. In this study, a total of 476 participants completed the study. There were 207 HIV positives and 269 HIV negative. From the 470 subjects that had valid INSTI results compared to a 4th generation EIA, very good sensitivity at 98.99 and a specificity of 98.15. So these numbers are numbers that would need to be achieved in Canadian studies. So again, we see very good usability. However, still, there was this 85% rate of failure, a 15% rate of failure in being able to collect blood. And in the contrived results interpretation, 91 participants correctly identified the strong positive, negative, and invalid results. However, there was an issue with weak positives. and only 31 individuals from this study were able to identify a weak positive, and this was likely due to the version of the package insert did not have an image of a weak positive. It only showed a strong positive. So lesson learned, you got to have that package insert correct. Otherwise, people are just not going to be able to follow it. So again, good overall usability in the Kenya study. Moving on to the H-003, which is a follow-up study in South Africa. Again, this was a very similar study designed to Kenya. This was a much larger study with 850 unassisted HIV self-tests being conducted. From this study, okay, great. Again, if we'll just look at the bottom line, the sensitivity, again, was 98.99%, so 98 of 99 correct results for positives. And specificity was 100%, so no false positives in this study. And lessons learned from the first two studies, if we just look at that bottom right hand, we finally were able to get a very good usability aspect in blood collection. And this is simply a result of redesigning the package insert, learning from the first two studies of what we needed to do, make the pictures more clear, and lo and behold, populations were able to get it correct. So the IFU mitigations led to significant improvements in fingerstick blood by getting the drop to fall into correctly into the first vial. And the last study we did was in the Republic of Congo. Again, this is a study in a low prevalent population. The WHO considers anything below 3% to be low prevalence, and Congo has a prevalence rate of just under 3%. In this study, it was done in the urban centers. About approximately 75% of the 4 million people in the Congo live in two urban centers, Pointe Noire and Brazzaville. And so the study was done in these two centers. Again, this was a prospective observational cross-sectional study similar to the South Africa study. So usability, interpretation, and comprehension. And the results in this case, very good again, 100% sensitivity and 100% specificity. And once again, we saw very good usability, including the successful blood drop collection. So this was sort of a verification of the data from the earlier study, from the H-star study, that showed that the package insert is indeed looking like it's ready for prime time. So lessons learned. Use of a free-flowing blood drop instead of a transfer pipette was feasible, but modifications to the IFU were necessary to improve the success rate. The overall acceptance of a blood-based self-test was very high across a broad cross-section of intended users in sub-Saharan Africa settings. The overall usability and results interpretation of the INSTI test by intended users was very high. Self-testers did have difficulty comprehending the image for the removal of the tab from the Lancet, which is this very simple lesson learned. We showed one hand holding a Lancet instead of two, and people didn't know what to do. So further revisions of the instructions for use, illustrated invalid results for different kinds of invalid results. That was a necessary change. And the majority of participants, this was interesting, would prefer to do the INSTI self-test at home rather than in a clinic setting. So next steps. The performance and sensitivity meet the minimum FDA requirement, where the lower bound of the 95% confidence interval has to be greater than 95%. So these types of data would certainly pass a Health Canada study. And in fact, these studies are about to begin in Canada very shortly. We're working with Sean Rourke and others to get these studies underway to bring this test here and see if it's going to be a usable test for folks in this part of the world. The instructions for use is very critical to ensure that the testers of all literacy and socioeconomic levels can complete the test correctly. The blood-based self-testing was accurate and easy to perform, and as a result of these studies, the INSTI test became the first blood-based test to receive WHO pre-qualification, so it's now in use in a number of countries throughout the world. And we are underway with pre-submissions with the FDA and also with Health Canada for studies of this self-test. You can hear more about those with, on Saturday in the testing session. And Biolytical is continuing to work with a number of research partners towards investigational studies of the self-test in key populations. So thank you.
Thank you, Rick. Any questions of clarification for Rick? Also bang on with the timing. Okay, our final speaker today is Suzanne Nicolay. Suzanne works with Wellness Wheel out of Regina and is going to be speaking to us about point of care and pharmacy settings.
Good afternoon, everybody. I'm happy to be here. Thanks, Sagandi, for the invite. So I'm Suzanne. I'm a nurse. I am from Treaty 4 territory. I'm a settler. And I just want to acknowledge that we are on Treaty 4 territory today. And I just want to thank the ancestors of the land for sharing their homeland with us. And I'm honored and privileged to be here. Okay, so I'm going to try to stick to my slides so I can keep in my 15 minutes. So I'm going to talk a little bit about how we came to do pharmacist-delivered HIV point-of-care testing in Regina, how the project was implemented, some of our challenges and successes. There's always questions around pre- and post-test counseling in terms of the pharmacist, so we'll talk about that a little bit. And then just talk a little bit about linkage to care and some of the other pieces that came up during our process. You will probably have these burned in your mind by the end of Sunday, because I'm sure lots of us will show these slides. So just to give you an idea of our rate, which I'm sure most people are aware in terms of what's happening in Saskatchewan, it has been going on for more than 10 years. I also want to draw attention to the number of tests. So certainly there's been a lot of work done by a lot of really awesome people over the last 10 years at least to increase the number of people getting tested, having access to testing. And that's really great. So you can see from this slide, this is from the Ministry of Health, reporting that there has been a 71% increase between 2008 and 2017. So by no means does that it's amazing, right? It's a really good piece of information. I think what is important to realize is when we look at our population here in Saskatchewan of 1.16 million people, we're actually testing less than 7% of the entire population. And I think we also have to have another caveat in that some of those tests that are being reported, those are not individuals. So we're not testing 81,000 individuals. Those are 81,000 tests. Okay, so some people might have 2, 3, 4, 6 tests in the course of a year, right? So I think just to frame how many people are actually accessing testing or getting tested, I think, while we've made strides, we still have a lot of work to do. So that give you some background in terms of where testing has come from. So certainly the HIV strategy that was launched after the last CAR conference here in Saskatoon. So I'm hopeful maybe we'll hear some more good news about another influx, but maybe not. We had access to point-of-care testing start in 2010. And so that has continued to expand across the province. And it's largely accessed through public health types of sites. So depending on where you live, you may or may not have access. What we know about point-of-care testing is while it's an amazing tool to have, as one of the earlier speakers says, none of these testing options are panaceas. So there's no one size fits all. So when I go to communities, we have a conversation, especially in on-reserve First Nations communities, is this something that you want me to bring for a wellness event? And largely the answer is no. They've been more receptive to other point-of-care testing technology, but not to HIV, largely because there's a lot of stigma still, lots of discrimination, lots of lack of knowledge, awareness, lack of ability for connectedness to care. There's just poor access, period. In addition, I leave at 3 o'clock at the end of the day, and who's in the community in order to provide support for that person who may have tested positive. So unless we have the discussion, certainly, and if communities would like it, absolutely we'll bring that, but largely we do not. In 2013, there was a provincial offer of HIV testing that was promoted and has been widespread through various means across the province in the last 5 to 6 years. Lots of provider messaging, routine testing, routine offer of testing should be recommended at least every 5 years for everybody, and then more often depending on your risk factors. I would say, as someone who was part of delivering that message, particularly with physicians, that there was a lot of challenges there. So I had to book an appointment, it had to be over lunch, I had to bring lunch, couldn't just show up and talk to somebody, I had to bring food, not unlike in my own household. If I want everyone's attention, I have to have food. But it was just a really difficult conversation. There is a lot of pushback in terms of, well, I know who to offer testing, or I know my practice, right? From people that I was shocked, people involved in sexual health that were just offended that we would suggest you should offer it to every single person coming into the clinic. Usually my response is, I don't always tell the truth to my family doctor. I haven't over the course of my life. I'm probably more truthful now than I was 20 years ago for various reasons, which I can discuss with you later. I'm not going to go into that now. But lots of us don't tell the truth for lots of reasons, mostly around shame, I should know better kinds of things, right? And if you had a family doctor like mine that's in a biathlon, doesn't drink alcohol, doesn't smoke, it's kind of annoying, actually. So in my past life, I was the HIV coordinator in Regina, and in that role, I connected with Dr. Skinner, and he connected me with a pharmacist. This was in the spring of 2016, and a small group of pharmacists that worked in a community pharmacy really were concerned about who was not getting tested, or who they perceived was not being offered tested. They weren't sure, but they were seeing, in particular, people who were on methadone that they didn't know that these folks were even being tested. There was no evidence that they were, in fact, HIV or hepatitis C positive. So what could we do around that? So we had this conversation about how could this look, how could this work. There are lots of challenges in terms of doing that. So we sort of thought, well, what we'll do is we'll have a partnership and we'll offer lab requisitions to the pharmacists with Dr. Skinner's name on them. We'll talk to the pharmacy team about how to have a conversation, offer a test, how we're going to document that, follow-up, results, all the rest of that stuff through public health. That particular pharmacist left and went on to medical school, and so the conversation went away. And then later that year, I actually left my job and joined with Stu in Wellness Wheel. And so we were having different conversations then about how we could do this and how could we be innovative and really try something new and different. So kind of what opportunities existed. So we had this conversation about maybe actually doing the HIV testing right in the pharmacy, and how cool would it be if we could have the pharmacist do the testing. So that was really a great idea, but again, in Saskatchewan, there's some challenges. There's a Medical Lab Act, which says that only registered nurses, lab-trained folks, and physicians can actually do point-of-care testing. So pharmacists aren't on that list. In addition, there's the Public Health Act in Saskatchewan, which talks about reportability of communicable diseases, and it talks about labs, physicians, and nurses reporting, but not pharmacists. Now, I hadn't actually told the pharmacists that they could get out of that. I mean, they just knew that they would have to report, end of story. But the legislation has been difficult to navigate that. In addition, scope of practice for pharmacists is limited. So under their scope of practice, they're actually not allowed to do this particular thing, even though lots of pharmacies and pharmacists offer point-of-care hemoglobin A1Cs, random glucoses, other things. Some of the pharmacies do urine drug screens. That's a point-of-care test. But there's a lot of lack of information, I would say, around lab testing and lab information. And then funding. So where are we going to get the money to do this, right? We had to talk about that. So we were fortunate to get a pivot grant through ViV Healthcare, which has supported our project. And then the next hurdle was ethics. So this was a really fun experience if anyone's gone to an REB. And probably the thing that sticks out in my mind the most was a pharmacist in the meeting who was worried about the pharmacists performing the test getting hepatitis A and hepatitis B. So I thought, okay, so we have to kind of roll this back and have a totally different conversation. They were very worried about the pharmacists acquiring HIV. I wondered if they would have the same concern for hepatitis C. So we had to have conversations about what the Lancet looked like, and it wasn't hollow bore, and it was retracting, anyway. I went back to the pharmacy group and we had a conversation. We really, at the end of it, wanted to have feasibility and acceptability information about the project from both the pharmacist providers, the pharmacy team, and from the clients that were accessing care. So I've talked a little bit about scope of practice. So we did get approval through lots of dialogue with the College of Pharmacy Professionals to allow the pharmacists to do this point-of-care test for a 6-month project. So we started in December, and we'll be done soon. The pharmacists were trained a couple of times. So we did an initial training session last January of 2018, thinking that we were going to start right away. It took us a really long time to actually start, which was then December of 2018. So we did a refresher for them, and they were amazing. I've trained lots of people in point-of-care testing, mostly nurses. By far, sorry for the nurses in the room, this group of pharmacists did way better than any registered nurses I've ever trained. They were spot on. They asked really great questions. They were thinking further than just an actual test. They were thinking big picture, right? So they were asking questions then about what about PrEP, and what about PEP, and what about harm reduction, and where do we tell people to get clean equipment? So they went far and beyond what we would normally think about. The linkage to care and delivering results, I think, caused some unease. So we had a lot of conversations about how to have those difficult conversations. How are you going to deliver the results? What are you going to do? What if me as a nurse, what if I'm not there and you have to give somebody this information? How will you handle that? How are we going to get them to the general hospital? So we connected with our public health folks. Mike Stuber was on our team, and he's the infectious diseases clinic pharmacist. Dr. Skinner was on our team. He's well connected. There's a medical clinic next door with an excellent nurse practitioner and other providers, so they knew we were doing this. And in addition, the small group of pharmacists are absolutely amazing people. They are very frontline based, oriented clinical pharmacists. We needed to get a lab license, so nothing could happen until we had the lab license. Well, but pharmacists really aren't supposed to get a lab license, right? So anyway, we magically got a lab license, so that was great. We got our ethics approval. We have standard work processes for how we're going to manage people if they show up, when we're going to reoffer testing, how we're going to get them from A to B, what if they never come back for the confirmatory testing? What does that process look like? We really focused on people over the age of 18. We focused on people who were already regular clients of this pharmacy, so this was not just John Q. Public walking in. That said, we had a fellow who phoned from Moose Jaw, Saskatchewan, 45 miles down the road, reasonably sized city, 35,000 people, did not feel safe to access HIV testing in his home community. He is straight identified. He was worried about a particular interaction, so he drove from Moose Jaw to Regina and spent an hour and a half with the pharmacist and the nurse that day. So it was a really kind of amazing experience, and sad at the same time that he didn't feel safe in a bigger center and had to come to Regina, but nice he got tested. This is only HIV testing at this point, but we have other things in mind. So that's our poster, that was our promotion. Overall, the acceptance rate was 37%. We've only just finished our midpoint analysis of 3 months. The third into the fourth month of data collection, it looks like the acceptance rate is around 60%, which is pretty cool. Shocking, I think, 43% reported no previous HIV testing. And speaking as someone who's counsels a lot of people and says, when's the last time you were tested? People overestimate when they were tested. So I think this number is actually higher. We aren't able to tie it to eHealth, to the lab system, but I think it's probably higher than that. 40% of those were on opiate substitution therapy. 67% of people so far have been recommended to have additional testing, so ongoing risks, for example. And there have been a number of people who've been tested initially and then have come back to the same pharmacy. They've already signed the consent, they're part of the study, but they want repeat testing. So we've been doing that for them. We have had not a single reactive result, so I'm happy about that. I don't wish anybody to sort of go through that process, so we're going to keep monitoring that. We definitely have seen reduced stigma, so lots of really good conversations in a more open forum with the pharmacists and their clientele. One of the first guys they tested was a fellow in his early 80s who is still sexually active, and he pays for sex, and he thinks you can tell by looking. So they had a lot of conversation, and it's an ongoing conversation with this fellow, but I think good and opened a lot of doors. And there was some misconceptions, I think, even in the pharmacy team around who should be offered testing and when should they be tested. So I think myths just amongst the healthcare providers was really cool, and these pharmacists are sharing that in their circles as well. We also had 4 individuals that were hepatitis C positive previously diagnosed that had fallen out of care, and they've now been linked back into care. I think just anecdotally, it's been a really positive experience. The acceptability and feasibility from both a pharmacist standpoint and a client standpoint has been really good. When we do the client surveys, almost everyone hands down would recommend this to their friends, to their colleagues. They would come back, no problem. It's a supportive environment. We do have a poster here. We got turned down for an oral, sadly, but if you want to come and see us at the poster, we're happy to talk about that. Christy Matichuk, one of the pharmacists, will be there, and she'll be happy to talk to you as well. So I just want to thank folks that have been involved. That's Christy and Sarah. They single-handedly offer most of the tests. There's a third pharmacist who's not there as much, but I think we rival the local public health department in terms of how many tests we're doing on a monthly basis, which is pretty cool. And that's it. Thank you very much.
I am so impressed. I have never moderated a session before where all 4 speakers stuck to the time that Sugandhi had obviously very intentionally pounded into their heads that they had to stick to time. Any questions of clarification for Suzanne? Yep. Hi, Jason.
Are you guys looking to expand this throughout the province?
Thank you, Jason. The short answer is no for me, because I'm a nurse and so I can't push this. So the pharmacists that I'm working with have had some dialogue with the college, and so we'll see where that goes. I think initially when we discussed this, there was always the worry about the slippery slope. Oh my God, all these pharmacies are going to want to do this. They're going to be unsupported, blah, blah, blah. I don't think a garden variety pharmacy is going to want to do this. I think this is certain pharmacies and certain pharmacists. It's a specific individual or setting where this is appropriate, and there's lots of ways to support people. I would love to see this expanded to other pharmacies. Pharmacists are probably the most accessible healthcare provider ever in our communities. You know, they're there more than physicians, more than nurses. After hours, weekends, there's lots of reasons to utilize pharmacists, and certainly with support, this is easy to expand, I think. So.
Sean, can you go to Mike?
It was more of a comment, just wonderful work, and I guess I'm just surprised that, so if you're the health minister or a medical officer of health, you see these results, you should have got an oral. So we should talk to Cara about why you didn't get one.
Yeah, I'll put a complaint in my evaluation.
There's no reason, seeing this data, seeing what happens, seeing how you could re-engage people in care, it's actually, it's striking to me, the work that I'm doing now, doing this area, that if you're, whichever province you're working in, and I'm sort of connecting with a lot of them, when you see this data, it's hard to argue not to scale it up. And so for all of those people in the health and the public health sector, this is just something that we need to just keep on pushing, because it works and it engages people, and it's the solution. So just a bit of comment, just wonderful work.
Maybe you want to stay for some meetings after CAR. We can go to the buildings in Regina.
So Suzanne, how did you handle the remuneration for the pharmacists? How did you handle the remuneration for the pharmacists?
So we were funded through Pivot, and so as that, we budgeted for a certain number of pharmacy hours. So we offer testing 2 days a week, and they bring in an extra pharmacist on those days. So Sarah and Christy, who are trained, are paid from the project, and then the pharmacist is on staff the other days. If they don't have an extra pharmacist, they typically don't do the testing.
Okay.
And then usually myself or another nurse named Vicky are there to support the pharmacist. Mostly we do other work because they're very self-sufficient.
Okay.
So we just answer questions, but
So did you do it per test or per time, or?
they just get an hourly wage.
An hourly, so whether there's 1 or 0.
That's right.
They're still getting paid?
Absolutely.
Yeah, okay.
And they do other work while they're there because they're busy, right? So, but recognizing that if you get pulled away for an hour and a half like the one fellow, I mean, it's a big chunk of time.
And actually, I just want to respond to a comment that Sean made. On Saturday, there is going to be a description of that possible rollout of a pharmacy-based implementation for rapid testing. So if you want to hear more about what may very well happen outside of Saskatchewan, just please attend the Saturday session.
Hi, quick question. What process did you put in place in the end to do your public health contact tracing in the event of that potential reactive?
We had some food with the public health people, and we all sat around a table and just chatted, basically. Regina's small. They already knew some of the public health nurses who do the follow-up. The Regina General is not far down the street. So it was just a matter of connecting people face-to-face and having phone numbers available and just saying, you know, if you need me, just call. And so when we started, we make sure they knew that. And so they have lots of support there, and they can always get a hold of Vicki and I by phone. So if something ever did happen where it was unexpected, you know, they're probably going to call us first and then go from there. But they're both, these two pharmacists are amazing. They would handhold people to wherever they needed to go, right? So
the idea would be that if you had a positive reactive, you would take them or assist them to get serology that day, or?
Well, ideally, the nurses were there to draw the blood work.
I see, okay.
So in Saskatchewan, if you have a reactive point of care test, it's reportable at that stage without confirmation. So they were already schooled in, you have to phone the local public health office, report it to the MHO, try to get the blood work. If we can't get the blood work, if the person leaves, for example, we had plans in place of how we were going to tackle that. But again, these were all people that were known to the pharmacy, so we had really good information on them.
Okay, thanks.
If there's not any other questions of clarification for Suzanne, I'd like to open it up for questions for anyone on the panel. You may also have questions that you want to have everyone on the panel answer. And I would suggest, to make it easier for everybody, if in fact you just move that mic back and forth, and then you don't have to get up unless you want to. So I see someone. Maybe people can, I know at the beginning people introduce themselves, but maybe for this discussion, if you can introduce yourself at the mic before you ask your question.
My name is Oralia Gomez Ramirez. I work at the BC Center for Disease Control. And so my first question is for Nate. You briefly touched or spoke about liability. I wonder if you can expand on that. And I maybe missed this, but if you could talk about the positivity rates among those who didn't agree to be contacted after. And then for everyone on the panel or anyone who would like to comment, all of you talked about promising innovations.
Can I just ask you, you can get the next question. You can, okay.
Sure. So on the second question around positivity rates, we're not going to share that data today. We still have a process in terms of community consultation to talk about that, so sorry. And then in terms of liability, I think, so this is a complex partnership, right? So we have a university involved, we have a community-based organization, and then we have other partners across the country. And so, so the University of Victoria was interested in the concept of, well, who are we responsible for, right? So I'm a staff at the University of Victoria, but then there's people who are employed through dollars that flow through UVic for this project at other places. So how far does their responsibility reach? So that was kind of one of the things they were interested in. And in terms of liability, I think they were interested in things that were kind of talked about by other speakers as well, thinking about, is there some kind of risk if someone might acquire HIV through doing this? So that was kind of their piece. I mean, we went through a biosafety protocol and things like that. So, I mean, I think it was just a process and a conversation that we needed to go through. And I think a lot of that is, it helps you just prepare proactively to try and avoid any unintended consequences, but also make sure that you have a plan in place if something did happen. So does that answer the liability question? Yeah, okay.
So my second question for anybody or everyone on the panel, you talked about some very promising innovations to improve testing and testing access, and I'm wondering if you can comment on how these innovations might also help improve access to care, and then how these innovations might support the end of HIV-related stigma.
Well, I think there's a couple of issues. One, I think, is late presentation with HIV with regard to testing. And we've seen that in Manitoba, we've seen that in BC, recent report about people who could have or should have been caught earlier by the system and offered an HIV test and weren't. Some of them were symptomatic. So this issue about having testing available, whatever form it is really important, because now we're starting to see people who essentially have AIDS in a first world country, right? With all our technology and healthcare system, people in their first HIV test are being diagnosed with AIDS, right? And this particular poster is a strategy that we applied in Manitoba, and it's called Test for One, Test for All. And it wasn't just about HIV, it was for syphilis and gonorrhea, and it involved the urine test as well. And we rolled this out during Aboriginal AIDS Awareness Week in December at a training center for Indigenous people in downtown Winnipeg. About 100 people showed up for that event during the afternoon. And I think there was 23 tests that were taken that day. They were the blood draw, but we offered 3. We offered point of care, we offered DBS, and we offered the blood draw. But it got kind of confusing because they were doing the urine sample, so they decided to put them all in one section. And so people chose the blood draw because that's what they were familiar with. And we believe that there was some bias for the blood draw, because we wanted to see what the uptake of the DBS, if it was a different part of the room, if people just went to that booth first, would they choose point of care, would they choose DBS, or would they choose the regular blood draw? And because they were all in the same area of the room, they tended to more take the standard blood draw. So that kind of skewed our process, because we didn't realize it was test for one, test for all. So just that kind of thing. So that's what we're experimenting now is not just HIV, but the other STIs, and what tests would fit with that. Because I know with John's work around expanding what DBS can detect. Did you want to say anything about that? No? You got it.
Yeah, if I could just comment around the self-testing aspect. There's a lot of important questions that are being developed around the implementation of self-testing, in particular concerning the linkage to care. This is something that needs to be addressed now before these tests get here and get into widespread use. What are going to be the mechanisms for linkage, and how are people going to access that? Are we looking at digital health technologies such as mobile apps or web-based technologies to allow that to happen? Are we working with community groups to present themselves as maybe the first point of contact to kind of stick handle that linkage? So these are really important questions that you don't want to see become barriers to self-test implementation. And the other question is around procurement. Can you expect that self-tests that maybe are sold only exclusively in pharmacies or online, are they going to reach the populations that need to be reached? Are people going to want to pay for that? Are these the most marginalized or the highest risk population segments that are going to access it through a pharmacy? Likely not. And so these types of procurement and access to self-tests are going to also be important to address before these tests become available. And work is underway now to try and bridge that so that those gaps don't exist when self-test becomes a reality in the very near future.
So just quickly, I would add that for me, having tested lots of people, given results, positive results, home visited people cold and had the misfortune to tell them they're HIV positive, and focusing largely on that more at-risk population, this particular project, I think, really has the potential to reduce stigma and normalize HIV testing, because in this particular pharmacy, they probably have 700 clients, of which about 75 are on opioid substitution therapy. So the vast majority are garden variety diabetics, people in renal disease, getting their happy pills, whatever they're getting, right? I mean, could be me going there. And I was able to have the good fortune to hear the pharmacist offer the testing just you walk into the pharmacy. Hi, Sugandhi, how are you doing? You know what? We're doing this project. Do you want to get tested? Everyone should get tested. So the conversation was just very normal. It was just part of their regular day's activities. And there were some people that said, oh, I'm not sure. And they're like, oh, well, it only takes, 15 minutes. And then they would change their minds. And then they would bring their husbands back, or they would bring their teenage kids back. So I think that speaks to, again, having different conversations. I think that's, if we leave it in the hands of, physician A in this particular clinic, and they choose or don't choose to offer the test based on how someone looks, or whether someone asks for a test, I think that's not normalizing HIV testing. So I think this is very driven to ask every single person. Our goal was 100% offer rate. So I don't know for sure that we've got that, but they try really hard to ask people, given that we're only doing it 2 days a week. So we'll see what happens in the future. Hopefully we'll be able to do some form of testing moving forward. They are pushing hard to be able to do that. So for me, that's the brightest bulb around normalizing HIV testing that I've seen in a long time, for us anyway.
I guess, yeah, just briefly on the stigma piece, because I think it's a great question. Thank you. I think part of this also is about engagement, right? It's about making contact and having an opportunity then to talk about HIV and what HIV is today. And I think, those moments of relationship building and education are critical. And so I think those little things cumulatively contribute to larger work around stigma reduction. It's not just about the test and the test result, I guess is what I'm trying to say.
Doreen, are you coming to the mic? Yes, that Doreen. Okay, you were just coming to your seat? Or are you coming to the mic?
Are you talking to me?
Yes.
Oh, Denise.
Denise,
I
sorry.
have
Yeah.
all kinds of...
Starts
Dory
with a
is
D.
such a cool name, too. I have a bunch of comments. I don't know where they fit in the conversation, but thank you for inviting me up to the microphone as I got to my seat. So I've been writing for the last couple of days and participating in the Ready, Willing, and Able workshop. And so I'm here with my team from the Northern Indigenous Health Alliance in Northern Alberta. And we've done an adaptation, adoption, translation of Know Your Status in all of its worldly good. And so we are listening to all of the new technology that is coming out, and have to balance that with the concerns and dismay within Indigenous populations about the continued stigmatization of our peoples within research, within lots of different areas. So because we're speaking about HIV particularly and the technology, I know from the community that I work and am part of, what we've done to try to get a handle on the issue is to ask. We've asked since, and I have documentation from 2007 asking what was then First Nations Inuit Health Branch to provide us with the technology, the access, so that we could find out what we are dealing with. There is a level of concern and the gatekeeping that occurs and the power differentials, if you will, that occur between those that are caring for and saving us Indigenous peoples, and I'm not centering anybody out, but I hope some are uncomfortable, and I mean that in a light way, that there are people that will like to tell us what to do, but not actually have a conversation with us about our protocols, experiences, and aspirations for health. So we are moving out of your language of focusing on trauma and harm reduction to what are our aspirations for health as Indigenous peoples. We need to get a handle on what is actually occurring. There is a fear once we know we're not going to be able to handle the demand for care that might come from it. And I can see that from the government perspective, that if you are responsible for Indigenous peoples, whether it's at a federal level or a provincial level, let's not even get into the jurisdictional issues, that there might not be enough resource capability to handle the number of people that are living with HIV, Hep C, STIs, and facing all of the other issues that bring us to the point of having the disparities and disproportionate rates that people really like to put up there. So I challenge people here, and I'm getting a little bit excited and agitated at the same time, because I love the idea of new technology and new ways to meet people where they're at. I do see the barriers that are still there because of the legislation, the funding, and the thing that I'm really aware of now is in our ask to be with our people in social and cultural gatherings like Albert mentioned, we know how to, we're not hard to reach. You have a hard time reaching us. And I say that because sometimes we have to just flip the perspective. We have gatherings of people that really want to know what their health status is. They want to know their status, right? But it's who's going to pave that way in, and I'm going to use the overstated in a good way phrase, so that it respects our sovereignty, our connection, our data ownership, that we're not another blood spot resource extraction. And that's where I am quite agitated and willing to have deeper conversations, because this is it's a colonial entrenched issue that we have not explored enough to be able to say, oh yeah, choo-choo, take my blood and do whatever you want with it. No, there are issues around Indigenous blood, and I think I'd just like to stop right there. Thank you.
No, and nobody's grabbing the mic. Oh, Nathan's grabbing the mic.
I just want to say thank you for, bringing the emotion into the room as well, because I think there's a lot of frustration, and I think that we need to funnel that into action. So thank you. I don't really know if I have anything else to say other than my piece of what I try to think about is what I can bring to this work, right? And so I think about myself as a researcher and the opportunity that research can play in starting to create little fissures, little cracks that then can that other people who have other positions and other skills can take forward. So I don't know. That's just, I think we all need to think about what we can do.
Suzanne?
Thank you, Denise, for that. You remind me of a gal I know from PA named Donna Leroy. Do you know Donna?
Oh, I do.
Yeah. I feel like you were channeling her there a little bit. I used to always say, I'm not scared of you, Donna, but I kind of am still a little bit scared of her. I just wanted to express my gratitude as well. I really appreciate you bringing that and saying that, and for us to hear that. And if we're uncomfortable, then we're uncomfortable, and too bad. So thank you for that. I have the very amazing privilege to go to some First Nations communities and be present on wellness days, as we call them. And those days are structured based on how the community wants the day structured. So the testing is offered based on what they want. We give them a smorgasbord of things, and they pick what works for them. And we work with them to make sure that they have all the information back. So we have an obligation to share all of that data back with them. And so I don't think it's common. I don't think it's easy for lots of us. But I know that for the organization I work with, that we do that. And we are held accountable by our partners. And we try to be humble and keep our mouths shut when we have to. So anyways, I just want to say thank you.
Yes.
Hi, I'm Cheryl Barton. I'm with the Persons Living with AIDS Network. We are an AIDS service organization, and I just want to say that what our peers say and what our elder has said is that really all they want to know is what happens after the test, right? When they break down on the floor at 3 o'clock in the morning and say, I'm HIV positive, oh my God, no one is there except their partner, their peer, their caregiver. And so when you're talking about testing, there's a human element to that. And there are organizations that struggle every single day just to provide those linkages to care, the connection, the transportation, all of those things to help these people along so that they can experience wellness. And when we don't get the funding that is needed, when we show that 30% of our clientele are inconsistent in care, and we need to reach out to them, and we show that on paper, and we get no funds to do that kind of work, that's when HIV goes from a virus to full-blown AIDS. And so I really just want to say that the human element to me is way more important than the test. Thank you.
Can I ask you back to the mic for a minute? Because I have a question for you. So, so you've raised a number of things. So aside from funding, which is obviously critical, absolutely critical, do you have any other suggestions for how, we're talking about testing here, so it's not just about testing, it's also about linkage to care and wellness, et cetera. But do you have any other suggestions other than funding, you know, improved funding, which I think everybody in the room would agree would assist, for how the human aspect of this issue of care can be, you know, more suggestions for what you would recommend there? So
it's the same thing I've been saying ever since I got here this morning. The Government of Canada has done their work on truth and reconciliation. They have gone across this country and talked about residential school systems. They have talked about generational trauma. They have talked about how Indigenous people need to be heard. And that includes HIV-positive peers. None of our peers are here today. Do you know why? Because they're not getting an honorarium to be here. They're not getting paid to share their story. They're not getting paid to be dissected. And where they are today is in that drop-in center, at their homes, at their kitchen tables, saying to the young guy that is about to go out and do drugs, use safe practices. The real advocates, the real champions, the real everyday heroes are those HIV-positive peers. And they make absolutely nothing, and they have no job. There is no security. We, as a community-based organization, go from year to year funding. And when that funding is late, it's not me who suffers, it's those peers. They don't get that $50 honorarium. So they don't go home with $50 in their pocket for sharing their story. We have to look at what the reality is for these people, and we need to build them up. And the only way we can do that is to go back to truth and reconciliation, to read those recommendations and to follow through. And if we don't know how to follow through, then go to somewhere like the Office of the Treaty Commission, get the education that we need, and start providing these people with meaningful employment and meaningful ways to provide for their family. They share every single day at their kitchen table. If we want this work done, get them to do it. They're more than happy to.
thank you. So maybe while do we have someone else at the mic? Okay, come on up.
Hi, I'm Baron from the Saskatchewan Infectious Disease Care Network here in Saskatoon. My question is about the self-test kit. I'm just wondering, based on our context here, have you guys asked the question of the counseling? I'm thinking that's basically out if I'm going to be testing at home, right? And with the majority of the population that's affected by HIV, I think that's very important. You know, not just counseling, even to have somebody next to them. And most don't even tell their next kin, the closest to them. So I'm wondering if that was one of the questions that was raised.
Yeah, certainly. On a global scale, the counseling, you're right. It's not going to be addressed directly in self-testing. Those of us in the industry that manufacture these products are being asked to insert some counseling elements, sort of HIV 101 or prevention aspects in the package insert in very plain language. But that's only a very small part of it. There are links to, for example, like 1-800 numbers, AIDS hotline. But the real issue here is that you're now putting self-sampling and self-testing in the hands of the individual. And what are they going to do? In Canada, we don't have very much experience. There's been some studies around that people are willing to phone numbers or, use web-based apps to get that information both pre and post-test. There are training videos that were going to be available online for people to consult. But at the end of the day, it's going to be up to that individual. No one's really going to intervene. If someone goes into a pharmacy and buys a test, or if someone gets a test given to them through a program, it's entirely on them. And that may not work in all population segments. There may be people that need to have that human contact in order to do it. In some of the study work we did in Africa, for example, the question was asked, do you prefer to do this test in front of a counselor, or do you prefer to do it on your own at home? The vast majority said they preferred to do it at home. So there is a state of readiness for those individuals, but not necessarily for everyone. So these are important questions, and we have to be able to have some choices and some options around how these self-tests are going to get utilized, but a lot of that hasn't been built yet. Yeah, so Nathan was mentioning, and it's a good point. There's also, what we call supervised self-testing models that are also a way of implementation. So you can have programs that will allow people to come in, do a self-test, and then talk to somebody. And then you can offer them to maybe even take a self-test home and hand it out to friends or partners. So there's the supervised self-testing, and there's been a number of studies showing that those are quite effective versus the actual self-test away from a supervised environment. So there are options around that.
Norma.
This is regarding the self-testing in regards to the community readiness. My name is Norma Rabiskin. I'm a nurse manager overseeing the 3 streams in our community, and our community has been transferred years ago, and we've been delivering all of the primary care, access to screening and testing. One of the things that I struggle with is the community readiness for the self-care testing. It's one thing, we're already overburdened at the community because the responsibility falls on the nurses. And in Saskatchewan, we have very unique service delivery models that exist. In our community, we're lucky that the services are delivered in our community. So we do come with our true realities that we're seeing at the grassroots. Number one, I know that this self-care testing is supposed to alleviate and get you to access care immediately, but really in the First Nations community, that's the biggest challenge for us. One of the things that when we have positive results, we have to go looking for those clients, and we have to do time-consuming contact tracing. So linkage of care is a challenge you're identifying. Well, there's a bigger issue is tracing the people and then linking to the specialties and also the case management that requires in supporting our people. We don't even address that. Case care coordination is a very time consuming because I've been there, I've worked with our people, and to navigate those services with non-insured health benefits also is a struggle. We have many challenges, so this is another added task that you're introducing as a promising practice, but you have to engage with the communities when you're introducing these. To us, we're just catching up. We're always 10 years behind. Technology, like I really agree with Denise. She speaks the truth because that's what we're facing as well. So that's why community also has to be part of the research. we can bring our own voice and advocate making those changes. And I talked this morning about the system, the Western system, and how they looked after our clients right now with chronic. They say that HIV is chronic disease. It fits in that chronic disease spectrum. But here in Saskatchewan, they're not even being looked after at the billing system. So the way the system is set up in our region, it's not meeting our individual needs as well. So until they recognize HIV in the billing system as an ongoing billing, the way they bill, the doctors bill, because right now there's only one person looking after that client, and the other walk-ins that they go utilize, they're not being compensated accordingly. So that's what we also struggle with. So though we have many challenges this is going to add more challenges for us anyway. So really, you really need to consult with the communities as well. Thank you.
Thank you, Norma.
Bonjour, my name is Laura Liberty.
Sorry.
It's okay, go ahead.
Nathan was just going to respond.
Oh, sorry.
Sorry.
I just wanted to make one quick comment. I think about in terms of the possibilities of redistributing the resources that we currently have distributed in certain ways, in certain inequitable ways. So I think about myself as a gay man who's tested numerous times. And I think about that those are not the best use of healthcare resources for me to sit in front of somebody, do you know what I mean, with the position and the privilege that I have, and that if I can use a self-test, do you know what I mean, and can do that, right, that we can think about how that might open up resources for us to redistribute where there is need for them to be there. So I think part of this is, I try and think about this also on like the systems level in terms of on what this could provide for opening up better use of resources, if that makes sense. So just something to throw into the mix. Sorry to interrupt you.
That's okay. Yeah. I'm Laura Liberty. I'm the HIV coordinator at Anishinaabe Nation, which is a political territorial organization in Ontario. And I represent 40 First Nations spanning across Ontario. And my role is to support our communities in providing HIV programming. And the challenges that I've come across is trying to explain how our holistic perspective is the best way to address the individual, and that testing is not a priority when we don't have the infrastructure to support the people who do test positive, and that understanding how we care for our people from a mainstream perspective is a major barrier. And I've seen and heard of examples where a young man that tested at a shelter in Northern Ontario and was afraid to receive his diagnosis because he was they were trying to follow up. He took his life before he could learn of his diagnosis out of fear at having tested positive. And I think that's a classic example of a gap in service, and why wasn't there a social worker to support him when he received his test, or even a cultural leader that can guide him and support him mentally, emotionally, and spiritually through that process. And I would welcome the opportunity to provide input on behalf of the Anishinaabe Nation communities to share how a holistic, driven perspective is the most effective way of helping our people. I've also seen like examples of mainstream organizations telling us what we need to do. And I've tried to work with a number of organizations, but have been so frustrated because there's this paternalistic viewpoint that they know better. And I'm not a researcher, I'm not a doctor, I'm really nobody, but I do represent these communities. And at the community level, this is what I'm seeing, that people's voices are not really being heard. And when it comes to the testing, I think that it would be a really scary thing to introduce in our communities because of the lack of general knowledge of HIV and the dependence on the web and Wi-Fi is not a solution for us because a lot of our communities don't have reliable Wi-Fi where the bandwidth is so small they can't download videos, or not everybody has a computer and not everybody has a phone, and not every community has reliable access to Wi-Fi. So that's a reality. Even myself, my office, I don't have reliable cell phone service, and I'm considered to work in an urban area next to North Bay. So I just wanted to add those comments, but thank you, everybody.
Thank you, Laura. And I just want to give a shout out to Laura because she's an incredible advocate for the communities that she works in. Sometimes it's calling me up at Katie and saying, why am I only getting 50 of those pamphlets? I need 1,000. And so you do great work.
Mine's kind of sort of half question, half comment. I've been doing I'm Shauna from Prince Albert Métis Women's Association. I've been recently, working on stigma and barriers. And I was reading that they do CBT.
What's CBT?
CBT over...
Can you explain what that is?
Cognitive behavioral therapy over the internet. And Skype and stuff like that. So in regards to testing, that could be an option possibly for somebody doing self-test at home and just having somebody on the other end, possibly, maybe.
Yeah, absolutely. I mean, I think the beauty of having sessions like this, where you're all getting a glimpse of some of the newest technology that's coming down the road, stimulates all these kinds of thoughts. Is it going to work in my community? Are my community members going to be acceptable? Is there a role that we can play in making this type of new technology acceptable to our peoples? This is what the purpose of this session is all about, because these are so important to know and understand what kind of mechanisms might work. Building a tool, getting that tool approved is the first step. Health Canada looks at these devices and determines whether they're safe and effective to be used with the intended populations that they're going to be administered to. But at the end of the day, you could have a great tool, but no way or no mechanism to make sure that it fits. And so all of these suggestions, and there's probably many more, are what we need to start working on now, so that we can start and be ready for when these tools are going to be, among the choices that we all have in terms of testing. So, it's great to have a session like this, to be able to brainstorm like that. And between us in the room and others and policymakers, you have to address that. And the time to start doing that is now. So I'm just encouraging more dialogue like this with various stakeholders to ensure that something like a self-test that is going to be proven to work very well for what it's designed to do is actually something that's going to work well in your population. And if it's not, then it's not. But this is the time to start addressing some of those gaps so that they don't become barriers to what could be a very effective tool to reach the undiagnosed. Thanks.
Rick or anyone else in the room who knows, the self-test kits that are available at Walgreens in the States, I believe they have a 1-800 number on them. Do we know anything, what happens when you dial that 1-800 number?
Yeah, it's a 24/7 hotline that the one company that has the approved product was mandated to do through the FDA. So people can call that at any time of the day or night, on any day of the week, and speak to a person. about anything from even how to do the test, technical information, or provide or ask about where they can seek care. Now, obviously, this is a manufacturer that does this, so they're not in a position to, do the actual linkage, but they can link with groups who are in the position to do that. And depending on where the caller is, they would have a list of where they can go to get help or get the information they need.
So they're not actually someone who's trained to provide what we would refer to as post-test counseling?
No, no, and that wouldn't likely, go through a manufacturer's. But there is the opportunity, and in Canada, that hasn't been established yet. So those of us in the Canadian industry side are still working with Health Canada to try and understand what are the requirements going to be. Will there be inserts put in the package that might have particular linkage information unique to different provinces or different areas, or some sort of a booklet? So that's still being written, but the time to address that is now.
Thank you. Jamie? Okay.
Hi, I'm Jamie from NCCID. This is kind of a question, kind of a comment. First, I was actually just going to talk about just what Rick was talking about, that there's all these great tools, and really we just need to find the best places where we can implement and use these tests, and that'll very much be about choice. And something to note, as an STBBI tester, people are using self-tests already. Because of stigma, people are not wanting to attend their caregivers or their care providers to be tested. So they're ordering tests from the States or other places and using them with very little instruction. So, providing that venue for people and providing access to counseling or to information, I think, is really important. Just to end off, I just wanted to say, I guess this is kind of a question. I think that this discussion about linkage to care will be really important, because I think what's getting us here in the first place, where we don't have people that, we don't have excellent testing rates, we don't have infections being identified, is because people are uncomfortable in care asking, or people aren't being offered those tests, or that is just not a part of regular healthcare and regular conversation. And so that stigma is leading us into this position where we have to find all these different strategies to move to get around that. But I think it's really important that we continue to make that connection to care, and because I think in the prairies right now, there's people who are testing positive for lots of different infections, and they aren't coming back for their treatment. And so that even if we are testing and identifying infections, that connection to care will be really, really important going forward in that comfort in care. So I guess this is kind of a question. How are we going to do that? And I don't think you guys have the answer. I think the answer is probably all around us, but.
So I appreciate the comments, and I don't disagree. I think that we need to rethink care. I think connecting to care or linking to care isn't necessarily a physician or a specialist or a public health nurse. I think care can be a peer, it can be a community-based organization, it can be an elder. So I think that that's part of reframing it, is that they're connected with somebody in that is meaningful for them. And I think the other piece is around care and treatment and follow-up, is that, again, I work with lots of people who choose not to engage in care, who choose not to follow up, and I think that I believe that that's their choice. And if you're a smoker, and I apologize to the smokers, but if you smoke, you know it's not the greatest thing for you, and I'm not going to change that by saying you really should stop smoking. So as long as you know what the risks are, then my work is done. And I view these other infections and illnesses and chronic diseases in the same way, is that my job is to make sure you're informed and that you know what the options are, and that the door is always open. That's my job. But people still have choice, right? I feel that anyways. And I think working in Indigenous communities, in First Nations communities, even that are only 60 miles from a large urban center, that access is not there. There is not equitable access to lots of things. And so that's why I agree with the conversations that Norma raised about connecting with community and engaging community and having good conversations, because it all sounds like a good idea when you're sitting in your office, you know, and you don't ever get out of your office. But if you go on the ground and actually talk to people, and especially with peers, I think that that's really where the answers lie in terms of moving forward. So, I mean, even asking peers, what do they think of self-testing? What do they think needs to be included? You know, what was their experience when they learned their results? What might have helped? What was, you know, would they have entertained that? I think those are things to consider moving forward.
Hello.
James.
Yes, I have a question for Nathan. When people tested positive from the dried blood spot, and then they wanted their results back, what was the model for reporting those positive results back, and how did that work across the country?
Yeah, great question. So, so for us, what's the best place to start? So I guess, I mean, the question or the issue of around legislation was brought up earlier. And so this was something that also took us a long time to figure out in terms of our protocol. But we're a community or peer-based process. So legislation does not require those individuals to report to public health. And so for us, the consent process, that was a part of the consent process. And so what we did was return information about an individual to that person, and we actively supported them to seek care and confirmatory testing. And so then once they're into the, I would say, more regulated clinical testing environment, as opposed to in the context of a screening research study, then that would be where that would link into the reporting process. So,
sorry, but who is the person that gave them their first, you're HIV positive result?
Oh, so that was the photo of Len that I put up. So
that was right across the country?
Yep. Yeah.
Okay.
Yeah, so we decided to send, so I can talk about that a little bit more. Is that what you're interested in? Yeah, sorry. So we decided to centralize that. I think in some ways it picks up on the conversation about having a central kind of process, which is for us divesting that to have during the one or two guys that were in BC and the one or two guys that was in each place, that there was a lot of value in centering that on someone. And I guess to speak a little bit in terms of Len's background, I mean, he did point of care testing in bathhouse environments and was doing and had a lot of experience working with during person-to-person kind of relationships. This is quite different, right? I mean, similarities, differences. But that was important to us in terms of that. We also worked to make sure that Len had supports in place, so that was something that was important to us as well in terms of a peer process, is that Len wasn't just out on his own. Yeah, and so that was centralized. And so, I mean, depending on how folks gave us their contact information, we reached back out to them in those ways. And we had a protocol where we followed up with folks up to 5 times, and we had a number they could call back into, and they could book an appointment online to talk with Len if they wanted that. So there was a whole infrastructure that we created around that, which was to, and I say this to all the other researchers in the room, that was not a part of our grant, that was not a part of our process. We did that because that's what we heard. And we did that because that was the way in which we could do the best that we could do. And we learned lots of things from that, so we're happy to talk to others. I think there's a lot of model here in terms of thinking about how communities can own these kinds of processes. And so very happy to talk to other folks about that if that's helpful to them. But yeah, hopefully does that, yeah.
And when the results were negative, did you talk to people about PrEP?
Yeah, great question. So the short answer is no. I think what we did, so we focused mostly on trying to return results to folks who had reactive results that didn't report knowing them already. So for folks who knew they were living with Hep C or knew they were living with HIV they knew that. And so for folks who tested negative for HIV, again, we kind of just said, you said you were negative, your test result was negative. And I mean, we had a passive process, I would say, in terms of linking them to information. One of the things that we've looked at in working with Sean and others around this is that in the future, can we add another peer-based process around support And to me, I think about this, I mean, we're at an HIV conference, and that is very easy to think about as the priority in people's lives here. But I think when we're in community and talk to folks, mental wellness, loneliness, those kinds of things are really what people talk about as their priorities. And so for us, I think it's about a broader linkage and support that we can do from a peer base. So if folks tell us on the survey that during they're struggling with substance use and they're not able to access services, that to me is where I think we need to be looking in terms of those linkages. So it's broader than just thinking about HIV linkage, if that makes sense for us. So, yeah. But no, we haven't done it yet, but we're excited to do it.
Okay, I think we're going to wrap up now, and I'm going to invite Sue Gandy up to help us close.
It was all tall people before me. Thank you to all of you who stuck around to the end. I truly appreciate it. Thank you to everyone who came to this ancillary. I know Nathan mentioned it earlier, but you could have been anywhere today, and you chose to be here, and that means a lot to us. Albert and Rick, I'm sorry I missed tiny bits of your presentation. I was running around trying to find water, which apparently was way harder than I thought it would be. By the end, I was just stealing it out of rooms and smiling at people while taking it behind my back. So that's where I was. And what was I going to say? Oh, I want to thank our panelists, our moderators. You guys are fantastic. I knit you each a mini washcloth as a token of how much I love you guys. But also, I'll hand it out in a second, but I would like to call Judy up, please, to help us close.
Okay, I'm just going to say a short prayer then. I just wanted to add to that. It's really good to see some of the Indigenous ladies and gentlemen that work in our communities speaking on behalf of those that don't have a voice. There's many, I know a disproportionate number of people with mental health and addictions that don't have a voice. Nobody hears them because they're the least of their worries is what they have. They're just surviving, especially in any inner city across Canada, and also on some of our reserves. And it's really good that we have such awesome people. And another thing is our group here in Saskatoon, our Woneska group. I see one of our members here, but so what an appropriate word to use for the theme of the conference. And we need to really rise up. Woneska means wake up, rise to the cause, especially of this very important thing. So with that, I'm just going to pray that we keep our minds and our hearts open, and especially to those people, like I say, that don't have a voice, and expert people here that did an excellent presentation. I've learned a lot myself as I go, and Sugani for inviting me to be part of this. So I'll just say a quick prayer, then that will carry us on with the rest of our day, and I will be here with you until Saturday, opening prayers and stuff.
Thank you, everyone. I wish you a wonderful car.
This is your sham.
Oh, yes, and of course, a plug for evaluation. Evaluation.